think one of the main takeaway messages we would like the primary care providers to have from this lecture on pelvic pain is that it usually takes several years for patients to find their ways to a specialist, whether it is a pain medicine specialist, a gynecologist, a urologist, a urogynecologist, whatever it may be. And rather than having patients try to seek out the providers themselves, having the primary care doctors know where to send these patients, I think, is really important, and knowing exactly what the therapies are that we could offer.
In terms of sending patients for evaluation, what's also important is recognizing that in managing pain, it's going to be much more than just a biomedical model. There are a lot of psychological factors that can influence the pain condition, and it's important to address those at the same time that you're addressing the pain itself. I think the current gap that I see right now is there are a lot of well-intentioned providers who are doing the best that they can with the tools that they have, but much of the care is still focused on biomedical approaches. They're not utilizing many of the other treatment modalities that are non-pharmacologic. A lot of times pain physical therapy is not included, a lot of times pain psychology is not included. At times that can be related to resource limitations, or it can be related to a lack of understanding of how these different disciplines fit into the management of chronic pelvic pain.
Yeah, I think that one of the main gaps in terms of treating pelvic pain is just understanding the breadth of conditions involved and the need to actually have this interdisciplinary ongoing communication where, for example, a patient might be seen by their gastroenterologist and they notice that they may need some help from a urologist, and all the meantime being treated by a pain specialist. And recognizing that a lot of the focus has been on treating different conditions, but the science has moved back a little bit to try to find real etiologies for things like painful bladder syndrome. And so I think that our approach is to pull back a little bit, and rather than experimenting with a lot of different therapies, looking for a real evidence-based strategy and approach. I think that as soon as they sense that there may be a pelvic pain problem, our message to all primary care providers, wherever they may be located, is if there is a pain specialist in your community that you can hook up with and other specialists, that to do that earlier rather than later on. As pain progresses over time and becomes chronic with many other conditions, there's central sensitization involved, which makes treatment a lot more complicated, and then there's the psychosocial overlay. So we want to encourage primary care doctors that it's okay to go ahead and refer early, and that we can create treatment plans together, and so hopefully patients are treated optimally, can actually get better and get back to work and get on with their lives.
I would agree with that. There's a lot of data that suggests that early intervention can really yield positive outcomes for patients. So the sooner that you're able to get people involved with interdisciplinary treatment, the better off they are, the better the likelihood that they don't get stuck in the vicious cycle with emotional distress, physical pain, feeding off each other, leading to lower and lower levels of functioning.